Good morning, everyone. I'm gonna set up here. I'm not looking at the chat, so I'm gonna ask for audience participation. I'm gonna ask that you unmute yourself and speak into the void. I'd appreciate it. This presentation is going to be part of this kind of morality and ethics series that we started this year that I've coined Morbidity and Morality. I'll start with some cases. Again, I didn't have any specific cases from our AMR institutions, but these will be familiar to everybody and not anything that we haven't encountered. So first case is you get a notification in CCT. You're getting a patient post-cardiac arrest. They'll be there in 2 minutes, which means they're right outside. They roll in, and you have a 99-year-old woman in a cardiac arrest with the Lucas on. She's pale, cactic. Reported that she has been declining over the last couple of weeks and has a stage 4 colon cancer. Next patient is a 75-year-old male, trached and pegged from a nursing home, being brought in for the third time this month with respiratory failure. Usually is on blow-by oxygen and then is requiring a vent to keep up their O2 sats, and they were discharged like 3 or 4 days ago after antibiotics. And then the third case is a 24-year-old male, minor head trauma, tripped and fell, isn't intoxicated. GCS 15, normal neurologic exam, and has like a small little abrasion on his forehead, and he is demanding a head CT. So what do you guys think we're talking about here? Are these cases familiar? Are they producing any shared trauma between all of you? What's the discussion today?
You're saying they all roll in at the same time? Do we have to prioritize them? Is that the discussion?
No. Definitely could feel like a CCT shift where they're all there at the same time.
Goals of care, perhaps.
Okay, good. That's kind of part of this. I'm going to leave it to Jeff today to talk about goals of care specifically. But what we're talking about is futility in medicine. Lecture's going to talk about kind of the concept of futility in medicine and kind of surrounding treatments that are not seen as beneficial. This is a picture of King Sisyphus from Greek mythology. He was condemned to the eternal punishment of rolling a boulder up a hill, only to kind of have it roll back down to the bottom after he finished, and to continue doing that to eternity. Sounds like working a week of pod shifts, kind of just continuing to go in that circle. Sisyphus was punished by the gods for his defiance, for his trickery. And it's kind of an interesting dichotomy in how people look at this myth. It's either just a symbol of futility in human endeavor, or is he a hero who perseveres despite his situation? Is it the struggle that matters and embracing the absurdities of life that can lead to a sense of meaning and joy? So definitely something we can think about in terms of facing futility in medicine, or just the practice of medicine. A lot of times is, are we just running against a brick wall every day, or are we fighting the good fight? So in the presentation, we'll be kind of talking about what medical futility is, why we should think about it, discuss it in emergency medicine, some of the kind of the legal background and aspects, and then just a general approach to it in the emergency department. So futility itself isn't really a tenet in medical ethics, but it's rather kind of a concept related to others. Last time I spoke about autonomy and the patient's right to dictate medical care, to make decisions for themselves. The consideration of futility and non-beneficial care is important in kind of a natural flow from that conversation. With the rise in patient autonomy as kind of a guiding principle that we make clinical decision, our practice can sometimes reflect like doing whatever the patient requests, no matter what. And then, with push for patient satisfaction, concern for litigation, it may seem easier and less risky to provide like futile or non-beneficial care. And then the other tenet we're talking about here is kind of beneficence, or maybe more accurately, the idea of non-beneficence. So we're familiar with this, right? This is why most of us, or all of us, got into medicine. We always want to do what's right or what's good for the patient. but it's a little more tricky to think about what the ethical implications of providing care are that are shown or thought to have no benefit. So what someone shout out a definition, either maybe just generally for futility or what you feel like medical futility means and specifically in medicine.
When you come to a point where increasing medical care will not come to a better outcome.
Good. Anyone else? Good. And I mean, I think a lot of this conversation is going to be feeling like end of life care or kind of when interventions aren't going to cause any benefit or mortality, but also think about it in terms of that non-beneficial. So, like that head CT and the patient who clearly, from our evaluation, doesn't have any intracranial pathology. And that test isn't going to add anything, or that, blood work to find out if the white count is elevated. So it could be interventions that aren't necessary or aren't going to change any outcomes. So, I mean, futility in general is defined as incapable of producing any result, ineffective, useless. And then thinking about it in medicine is kind of what we talked about, but also, thinking about a kind of tenet or a principle that physicians can use to kind of withhold therapy or interventions despite patient's family or wishes. And then, it can be thought about in a negative connotation of being like this is a covert way to kind of assert physician value. So be careful. There is kind of like a spectrum of this, and it is a way that can be thought of in multiple different ways. There's another picture from Greek mythology, one of the daughters of Daunus, who was condemned to the underworld to fill a bath with leaking vessels. They were punished after murdering their husbands on their wedding nights. Kind of sounds like flogging the hypotensive nursing home patient with fluids and pressors to keep their MAP above 50. So a lot of Greek mythology in terms of futility. All right, so definition. So you can classify futility in medicine in a lot of different ways. There's qualitative, kind of treating that merely preserves permanent unconsciousness, fails to end dependence on intensive medical care, will not lead to an acceptable quality of life. Quantitative, any effort to achieve a result that's possible, but that reasoning or experience suggests highly improbable. It cannot be systematically produced. Physiologic futility is just something that interventions that are just not going to produce that physiologic effect. Imminent demise is the idea that treatments may have a desired effect, like pressors on that end stage patient, but it's not going to prolong life. And then lethal condition, a patient will die or an underlying condition of an underlying condition regardless of any treatment effort. And then there's kind of an idea of is low efficacy treatment. So the idea that futility is just simply the end of the spectrum of any low efficacy therapy. So it's another way to kind of think about it, rather than just futility in a care of a patient, or just these kind of classes of therapies that have low efficacy in general, and we're just kind of reaching the end of that spectrum. You can think about epinephrine and cardiac arrest patient. So how do we think about this, or why do we think about this in the emergency department? Anyone want to kind of share what where this comes up in the ED, or kind of issues we have in the ED with futility in medicine?
Yeah, I have one. Sadly counted more than once. It's like bedbound, demented patient, come from nursing home, decubitus ulcers, septic shock, and full code. It doesn't feel good. Yeah.
Yep.
I struggle with, you find the patient that same situation that Dr. Gilbert just said, and, the goals of care are they're still full code, they want everything done. And you talk to the ICU because they need to be there, and the ICU rejects because either their beds are full or they think it's futile, and patient should get care there if they want to, continue treatment, but the ICU isn't accepting what exactly do you do with that patient in this scenario?
Yep.
Also, beyond like the obvious palliative care patients, we also have our patients that come every single day for various psychiatric or substance use concerns, sometimes multiple times a day. Yesterday, we had someone that came in 3 times in one day, and we all were like, what are we doing here? This is just a Looney Tunes episode where behind every closed door is this patient following us.
Right. I mean, that kind of gets into another realm of it as well, in terms of just, yeah, the kind of futility of what we're doing, for sure. But I mean, specifically in the emergency department, it's difficult, and I mean, it's difficult in any practice. But we often have limited time to develop relationships, the limited time to discuss goals of cares at length, and to kind of sit down with family. Difficult to gather individuals. And then we often have to need to make decisions emergently, or our attention is pulled in lots of different ways. The implications are significant. We dictate the trajectory of treatment very often, so the kind of decisions that we make are going to probably be carried out throughout the hospitalization and maybe even beyond that. And there's really no ethical distinction between withholding or withdrawing care, but likely a big emotional difference and kind of a kind of operational, practical difference in withdrawing care rather than withholding it up front. Incidental findings for diagnostic tests that we perform that may have no benefit. This could cause further interventions, invasive procedures, cause more harm, maybe down the line. So we may be kind of going towards causing harm to the patient. And then having these conversations or engaging in these kind of thinking about futility care can make you vulnerable potentially for lawsuits or kind of reviews in the hospital or having patient complaints. So that can be a barrier to getting involved in it too. Our responsibilities within the ED, obviously in the care for our patients, but also in a lot of hospital states, you're going to be providing medical command to emergency medicine, medical services, and EMS. So you may have to make that decision of withdrawing care or stopping care in the field. And then the idea of distributive justice. So ordering that extra test, spending more time taking care of that patient, is that taking away care or resources from other patients in the ED. So some of the legal aspects, generally, my big takeaway I want you to have from the legality of this is that you're overall pretty well protected in kind of engaging in the thought process and the idea of futility of care. But you really have to adhere to the EM standard of care in determining if the treatment's medically appropriate, and then think about what a reasonable, prudent emergency physician would do in those circumstances. Interestingly, New York has a specific statute that precludes withholding or withdrawing life-sustaining treatment if a surrogate directs otherwise until a transfer or judicial review. But really doesn't, that kind of statute doesn't really address whether the treatment is effective. So that's something to consider. If you feel that it's a futile intervention, it's not really preventing you from doing that. Malpractice cases regarding futile care rarely find the physician at fault. There are some kind of gray areas in terms of life-sustaining treatment like ventilation, artificial hydration, and nutrition when the patient's not actively dying. So not really something that is in our practice specifically. And then families have had or plaintiffs have had some more success when there's an allegation of intentional infliction of emotional distress, being reckless, extreme conduct, causing emotional distress, being deceptive or insensitive. So, kind of thinking about that in the realm of what you're doing and how you're doing it. ACEP has a pretty inclusive and long statement about futility of care and non-beneficial care. So I'm not going to read it at length here. I suggest you take a look at it. But basically, it's saying that emergency physicians are under no ethical obligation to render treatments that they judge have no realistic likelihood of medical benefit to the patient based on available scientific evidence and societal and professional standards. So this is important. This is, I mean, God forbid you are going to court or talking at an institutional level about a decision you made. This is your governing board kind of talking about what the standard of care is. So it's something to take a look at. General approach. So first step is to build rapport and trust. I mean, the goal is to do this for every single one of our patients in the ED, but you should kind of approach it intentionally and thoughtfully when you know that this could become an issue in the patient's care. There's really no right way to do this. There's a lot of ways to be successful in this way, but generally sitting down with the patient can be helpful, taking your time, attending to small matters of comfort, getting something to eat, a drink, a blanket if it's available, and then obviously avoiding jargon. Timing is huge. I would say timing in terms of having the time to do this, but also deciding if these decisions are urgent or when there's time to deliberate. If it's urgent, you may not have the opportunity to really get into a long discussion about goals of care or whether it is futile. You may just have to make decisions with less information. If there's time to deliberate, there's really no substitute for good communication, being curious about the person, the motives for the decision. Maybe they want to keep the patient alive for a little while longer to have the children be there or family to be there. That's not completely unreasonable. Maybe they want the head CT because of a concern for a totally different diagnosis, and maybe it is a reasonable test, or you can at least discuss why it's still not a reasonable test to do. Load the boat, bring in outsiders, bring in family. A lot of times you'll have access to primary care physicians. They can be helpful in these discussions too, and you can kind of delegate that to them. Consultants in the literature says have an ethical consultant come. I don't think that's very practical in the emergency department, but I've had a lot of times getting the ICU involved and intensivists having conversations with patients and families, and they can give a lot of perspective about what the next days, weeks of that person's kind of course and life is going to look like, and that can be helpful in having the discussion. I think one of the biggest takeaways I want you to have from this, and something that I definitely struggled with and maybe made not the right decision in the past, is that knowing your role in these conversations and decisions. The physician determines what effect a treatment is likely to have. It's not for us to determine what outcomes are meaningful. So that's really the patient's and the surrogate's decision to make what is meaningful. And I think it's difficult to not apply our values, apply our experience, what we see patients and going through in terms of these treatments. So that can be a really difficult part about this. These are a couple of like philosophical, ethical kind of tests and tenets. I think might be good if you're feeling like I'm not sure if I'm making the right decision, or you're having a lot of discussion or argument with the patient or their family. Put yourself through these and kind of see if you think you should move forward. First is the impartiality test. Would you be willing to have this action performed if it was you? So that's kind of the golden rule. The universality test. So would you be comfortable if all clinicians with the same background and same circumstances act as you're proposing to do? So this is kind of thinking about, is there a slippery slope? Am I just trying to apply this to one special circumstance? Should this be done universally? And then the last one is the interpersonal justifiability test. So try to provide or challenge yourself, giving good reasons to justify your actions to others. So this is, I like to think, like if there's an M&M in a month about this case, or an RCA, or I have to answer to hospital administration, and other reasons I'm doing this are going to make sense to them, and is it going to kind of hold water? And then don't be afraid to ask a friend. You may not be practicing in a situation always where you have colleagues available. I think the ideal is to have another colleague in your practice assess the patient, write a note agreeing with your assessment of futility, but it can also just be helpful to kind of bounce it off of them. Just want to take a moment to acknowledge, and I think a lot of you guys already kind of brought this concept up, being engaged in these conversations, end-of-life care, providing care that you feel is futile, even talking about kind of always being like the gatekeeper for testing that patients want, but you are not giving or you don't feel is appropriate, takes a toll. So reflect on this, discuss it with your colleagues, use your kind of whatever you use to kind of help yourself reflect on these and work through them. Therapy, talking to family. There are resources within the institution helping healers heal, specifically for residents of GME counselors. So overall, my big takeaways is that identify futile care, think about it. Don't just blindly apply all care to all patients and follow patients' autonomy. Think about, you're the professional, you're the expert. Communication is key, communicating with the patient, having those conversations, and then you're not alone, and that's kind of means multiple different things. Get other people involved, talk to primary care physicians, talk to the family, talk to your colleagues, and then also just acknowledge the effects of these kind of constant decisions and secondary trauma on yourself and in your career. That's it. Any questions?